So my role within CIFAS has largely been to analyze 3D images of the face. As Dr. Matson just mentioned, that any screening tool has to be accessible, and historically 3D imaging has not been that. So I'm trying to bring that to be more accessible, and in this talk I'm just going to go through some of the work we've done and where it leads up to the work we're doing. So a lot of this work is ongoing, but it's basically taking a little journey through the lifespan of the facial dysmorphism we see within FASD. Where's the... this one.
The screen button.
Apologies.
And it's the laser over here.
Cool.
Yep.
Lovely. So this is a kind of pivotal moment for me. I don't know if you recognize this head in the background there. And you can see who that is. Can anyone recognize whose head that is? Yes, that's Dr. Ken Jones. This was just over a decade ago. Ph.D. student me with no grey hair was out there on one of the CIFAS sites helping with scanning, and after one of the participants had left, about half an hour later, Dr. Jones came in and said, I want to look at this individual again. Can you bring up the 3D image? And my response was, yeah, cool. What do you want to know? And so this is a real pivotal moment. It made me realize kind of the work we were doing. I hadn't been in this field for much at that time, and kind of realizing that what we can do is actually potentially useful. It turned out he was interested in looking at the mid-face hyperplasia and seeing whether or not it was present, and we were able to give him a kind of quantitative measure of whether or not it was and whether or not he thought, because he wasn't really sure and he couldn't go back. The subject had gone. So anyway, when I talk about 3D imaging, we typically use large cameras that can capture surface geometry of the face, sub-millimeter precision. These have historically been quite expensive camera systems. This is a 3D image of the face, typically around 50,000 data points. More recently, we're now using handheld devices for a lot cheaper. It's still very accurate. Even more recently, we're using iPhones. The depth camera on the iPhone allows you to unlock your phone, is actually something that enables us to capture a 3D surface of the face. Morpheus Q, which is an app being developed within CIFAS, utilizes this technology, and we can then utilize. So the way we use faces is we create what's called a dense surface model. We bring all our faces together using anthropometric landmarks, and we can generate, we can compress this data using principal component analysis, and each one of these principal components represents the variation of the shape of the face. So this is really helpful because in particular, the largest variation when you've got age is growth of the face. And so we utilize these, and we utilize a whole load of other tools to try and decipher some of the features of FASD. And when we're looking at FASD facial dysmorphism, we're thinking of typically smooth philtrum, thin upper lip, reduced PFL. However, there are a lot of other characteristics within the condition that arise. And I think the reason they're not really utilized in clinical criteria is because they've historically been difficult to quantify, difficult to identify, and so they don't really form part of the criteria. However, they have been acknowledged, and they've been acknowledged for a while. And this is in the HOMI criteria, where you can see things like flat nasal bridge, mid-face hyperplasia, that's kind of flatness of the mid-face, retrognathia, are quite prevalent within FAS. But they're also prevalent across the spectrum. And so we've got a load of tools that we use using machine learning, computer vision to assess cardinal features, but we've also got some methods we can use to look at more subtle features, my favorite of which is called facial signatures. And this allows us to take an individual or group of individuals and determine how their facial shape and essentially the differences compared to a background control set. In our case, we're looking at age, sex, ethnicity matched controls. And then we can quantify these measures, and we can map them, and we can visualize them. It gives us an idea of where the differences are on a face, but also we can have an overall dysmorphism index. There's many other things we can do. I haven't got time to explain all of them, but when you see these faces, which you'll see a few of in a minute, when you see red in an area, that's where there's a deflation in that region. When you see blue, it's kind of an inflation compared to controls. And when you see green, that's when we're coincident with controls. That's when we're kind of agreeing with controls. So across the lifespan, this is kind of some of the work we've done. This is a recent study we've done looking at neonates from Brighton in the UK. This is a general population. This isn't FASD specific population. These were recruited from maternity ward about a few days post-delivery. The alcohol expressed was not, there wasn't much reported alcohol. There were a few cases. The cases that were high, we were able to provide Dr. Neil Layton, the clinician there, with some feedback on those individuals, which was helpful for him. But what we did discover was the mothers that drank pre-conception, who discovered pregnancy at 4 weeks, we saw no facial differences whatsoever. However, those that reported pretty much the same level of drinking during pregnancy, which was also very little, we did see some significant differences, and these are only a few days old. It is a small sample, but it struck me because two things there. Nasal length was significantly smaller, and PFL was almost significant. But there are some subtle differences. There was also 20 or so that had smoke exposure, and we can see there's a lot of red on the face, so that those individuals were statistically significantly smaller, and they also had that nasal length reduction as well. We know quite a lot about smoking. We know how they're small at birth, but then there is some catch-up growth. This is a part of the PASS study, the Safe Passage study, and we were looking at 3D images from the South African sites with the PASS study, and that was an extremely incredible study that looked at, had interviews for exposures, followed 12,000 pregnancies, and they looked at smoking, alcohol, drug use, and it had an incredibly detailed, rich data set. So from that, I was interested in that smoking result, to be honest. And at 1 month, so this is now at 1 month of age, we're going along our timeline, and at 1 month, I didn't really see any differences with smoke only. So not really seeing anything like we did in the neonates, so maybe there is that catch-up growth that we know about. However, when you add a bit of alcohol, there was a lot going on. There was significant reductions in growth, PFL, nasal length, mandible volume, and a whole lot of other things. And you can see this is growth. We're now looking at facial growth. But also, when we look with just a low exposure and smoking combined, we also saw something very similar at 1 month. When we look at alcohol only, those growth differences weren't really there, which I was quite surprised to see. We did see some other features. And then at 1 year, so this is a longitudinal cohort, so we have the same analysis at 1 year with the same groups of individuals. Again, continued smoke and continued alcohol exposure together seemed to have a concurrent effect on growth. The ones with the low alcohol seemed to catch up with growth. Smoking was still the same, and as was alcohol only. Interestingly, we saw some sex-specific differences as well. So we saw that the growth, PFL, nasal length, and various other measures were more statistically significant in females than in males, and remarkably so, actually, when we divided it out. And so these ocular measures, the nasal measures, are very important. We found at 1 year, this is what we were seeing, these kind of sex-specific differences. When we looked at the single exposures in a little bit more detail at 1 year, we saw that we were seeing some mid-face. These agreed with some other studies that had been done on children at 12 months. And the smoking, again, not really seeing much. When we start going into childhood now, one of the factors that seems to affect things greatly is the ethnic background. So different populations have different features, of course, and when alcohol is involved, those features are different. And so what we were looking at midline structures, we were looking at some of the things we looked at before, we're looking at the shape of the nose. This is discrimination testing to determine whether or not we can discriminate between controls and FAS individuals accurately. We found some differences depending on what populations we were looking at. And when we map them, we can see when we look at FAS, we can see the differences. We see the mid-face hyperplasia quite a lot. In the Western Cape population, we see it in Caucasian, then African American, we don't really see that. But we do see other things like mid-facial hyperplasia. I'm sorry, erectognathia, which is the red you see on the chin there. So another thing I talked about before was growth in the infants, and that was affected. And even in adolescence and beyond, we're seeing facial growth, is affected by alcohol, and it's extremely discriminating. So it's you know, this extremely significant. It was significant in every population we've looked at. Now, we're coming now into adulthood, and this is a part of CIFASD. This is ongoing work. We are currently collecting data. Dr. Susan Stoner and Dr. Claire Coles and are collecting data from 3D images. And so far, we haven't got much to go on, but I wanted to just share the preliminary kind of results we're looking at. We do see still in adulthood that reduction of facial growth, the PFL, and mid-facial hyperplasia. Dr. Susan Stoner has done a lot of work on this so far and looked at some of the dysmorphology from assessments in adults. I think this is a really important bit of work in adults because I just think they're totally underrepresented in the literature and in the field in general. I think there must be so many adults out there with this condition who either don't know it or have been misdiagnosed as something else. So if we can help in some way, that's great, and we can only help by expanding our knowledge. So back to this. Where we started there and where we are now are two very different times. This is over a decade ago. We didn't have access to machine learning tools. We didn't have low-cost imaging. We didn't have a lot of server cloud-based stuff like we do now. So my goal now and over the last 5 years has been to really translate what we've been working on, these techniques and these tools, to bring them into something that is utilizable for everybody with either researchers and people or clinicians. And so we have FaceScreen, which is our tool. It's an online tool where you can upload a 3D image. It's not quite live yet, so don't go there. Oh, no time left. I'm done, actually, so that's all good. Oh, 3 minutes. Okay. Was it mixed messages then, Mike? We have a dashboard where you can view the images you've uploaded, and they get stored on a database, and they get automatically analyzed, and a report can come back and basically provide some quantitative feedback on the face that we see. And a face can be compared to a set of exposed individuals and see where they lie in various regions of the face, and those regions of the face I've talked about that we find interesting, that aren't just cardinal features, and provides basically a quantifiable feedback and in comparison to generalized population. So just to conclude, 3D facial analysis can assist with the detection of subtle and cardinal facial features. But there are these other factors that we need to consider: ethnicity, sex, especially in infants, and other exposures which seem to affect craniofacial development. In particular, we found that smoking and alcohol, even at low levels, may result in more severe dysmorphism. We've only got the data to do this at infant stages at the moment, but I think it's a set of interesting results. However, there are some consistencies throughout life that we see. Ocular measurements, eye measurements seem to be very consistent. Growth, facial growth is our metric of facial growth. Nasal length, the nose and the nose shape seem to be very important. Outside of infancy, we didn't see mid-facial hyperplasia in infancy, but we do see it in childhood and in adults. Early diagnosis is vital, but as I said, I think we should be doing more for adults. I just want to thank everybody, particularly people within CIFASD who none of this work would really happen. And of course, all the study participants involved, we were very grateful. Thank you very much.
Very interesting work. Thinking about the range of faces that you find with ethnicity and race and things like that, it seems like the challenge will be to be able to represent the control variation across geography. Any role for things like AI tools and such to be able to capture that kind of variation, like for example across Asia, for example, so that now you can look at an individual and see how they differ from that? Yeah, so it depends largely on background population that we have.
but we can apply like ethnic differences to a face in 3D. There's various AI tools that we can apply. And so yes, indeed. Yeah.
Oh, I just messed up. I'm just kidding. So I was just wondering if anyone was doing, I don't know, an ethnography or a forensic anthropology degree, could they use this on certain human remains to discover if the person or if the community had any prenatally alcohol-exposed community members, and what that would do?
That's a really cool question. Yeah, so we can. I mean, some of the work we did and some of the tools we've got have the ability to look at skeletal structures, and we've done it with other conditions. And we've just looked at skeletal structures and the differences in shape of the underlying skeleton from CT scans. So yeah, it'd be really cool. I'd love to do that. Cool.
Thank you very much. Our next speaker is Miguel del Campo from University of California, San Diego. This is forward, this is backwards, that's the laser.
Thank you. Good morning. So we're coming back to down to earth, where I will talk about manual physical exams mostly. And so my role in the CIFASD consortium is to run what we call the Diagnostic Telemedicine Resource. And basically what it is, it's to provide support to my colleagues, so that we ensure that we are all making the diagnosis the same way, and the classification of our research patients is consistent, and we can actually pull our data together, and it's a valid cluster of data that we can use. There's two things that I would like to talk to you about. One is the importance of the training. That is, how do we train other professionals to perform exams? Because obviously there's no capacity for me to examine the hundreds or thousands of participants that we want to examine in the consortium. And two, can we find better methods to train, and can we actually evaluate those methods to know what's working and what is not? So here we go. Yes, as you know, the fetal alcohol spectrum disorders is an umbrella term that has a range of different features, among which the physical features have been important. They were very important in the initial descriptions by Ken Jones and others. And in the 90s already, it was determined that there were three facial features and the growth component and the head circumference that were important. So these data comes from the studies that have been made using the Hoyme criteria in the last prevalence study that was in 2018 in 4 communities of the United States. And what we see is that the fetal alcohol syndrome, that is the group of patients that have physical features that allow for a diagnosis, is a minority of the patients, probably 10%, even much less when we use cutoff points like the 3rd centile or the need for the 3 features like in the 4-digit code or in the Canadian guidelines, where again the individuals that have the fetal alcohol syndrome are many less. So why do we even care about the physical features if that only allows the identification of very few individuals, right? Well, the reason is that the way we diagnose in all systems, in all different systems, is with 3 axes, right? The confirmation of prenatal alcohol exposure, the evaluation of growth and the physical features, and the neurobehavioral phenotype. So what happens to prenatal alcohol exposure is that, unfortunately, confirmation of prenatal alcohol exposure is probably the most difficult of the three, because very often we do not have the reliable information. Then, regarding the neurobehavioral phenotype, the specialists in psychologists and psychometrists tell us it is still not specific enough to be able to differentiate from other neurobehavioral phenotypes. So the physical features in some of the diagnostic guidelines have been used to confer specificity to the point that we can make a diagnosis without knowing for sure that there was prenatal alcohol exposure if the neurobehavioral phenotype is consistent and there are those physical features. What are the problems? We disagree. I could show you some graphs between Ken Jones and I. We disagree on many of the physical features when we evaluate them by so-called experts or people or experienced examiners, right? So there are no consensus definition of some of the features. There's issues with precision in measurement, whichever technique you find. It is difficult to assess the features, and with all these difficulties, how do we actually train? So we know that a precise diagnosis, or at least a consistent one, is essential in the clinic and in research. So as far as growth, I just want to mention one thing. You know, the Canadian guidelines have eliminated growth from it, no? I still think it is probably very important in some of the populations, and particularly, you know, in populations where nutrition is probably not warranted, and also the cutoffs, you know, the percentiles. So to really be below 3%, it's almost only in genetic disorders that cause growth deficiency. So this just tells us that there is probably a continuum, a quantitative evaluation of some of the features that apply to growth that we should be thinking of, right? Being shorter than the family is probably important. So I always use Susan Asley's Hemingway's photos because I think it's what best depicts the fact that a dysmorphic syndrome is stable across ethnic groups, across families, and we will see from the studies that Susan Stoner and others are performing that they are across ages, right? So we decided in the 90s that there were three main facial features that could be measured, that could be assessed with different methods, that were the short pulpebral fissures, the opening of the eyes, the smooth philtrum, the effacement of the pillars and the grooves, and the thin upper lip, right? The thin upper lip, which is a combination of thinness and loss of the Cupid's bow shape. Some measure the circularity in photos, and it's really a technique that allows to combine those two factors, right? But as you know, there is a great variability in these features. What's wonderful about this is that we really know it is specific to alcohol exposure, because even animal studies that were extremely elegant and very early on described with, you know, some imagination the same features in the mice. So we could see that alcohol, through its impact in the development of the cranial neuroectoderm, craniofacial neuroectoderm, was in fact the cause of these facial features. So in terms of examination techniques, some do it in photographs, others do it manually, but what is important for consistency is to have a stable technique. So for example, for the head circumference, that should be something that every pediatrician should be able to measure, but where you capture the maximum head circumference, and usually it's easy to train for that, right? But for the pulpebral fissures, at least manually, it's important to get very close to the face of the individual. It's important to have the exact angle, because if not, we're just measuring differently. And for the philtrum of the upper lip, we will see that we use these example images, right? So getting close to the face, using this specific specific angle because we know that at least when measuring in person, the Pythagoras theorem, we need to respect, the hypotenuse there, right? When you do it in photos, you just have to use different graphs. So basically, we use these images, and just imagine how limited it is that we use 5 template images from 5 specific people, and we need to compare there, right? So we obviously have to train to better understand, to know what we're looking for, not necessarily only comparing with these images, right? And we know there are great differences among ethnic groups, and they are very useful, but I think they need some training, and we will see an example after. So, because these things are difficult to measure and be consistent, we try to design some new tools. And the group at Blue Resonance with Ed Riley and Gans Chugalingam developed Morpheus-Q. That is a app that will assist in evaluating those dysmorphic features and hopefully make training more easier and more available. So basically, there is a 3D scan where we can take the picture and place some dots, and we obtain the measurement. It's great when there's light. But when there's no light, the outer canthus, you can't place the dot. So that is a big limitation, and that's why we use that cheap ring light that we get on Amazon. And then there is a mesh scan, which is automated, which just determines landmarks, like a little bit like Mike's techniques, but in just an iPhone. And yes, but it's very inaccurate, we have seen, or much more inaccurate, interestingly, although it's fully automated. And then we have a 3D scan, which is similar to what Mike was talking about, that is not exactly still life, but we probably will be able to take and analyze a 3D photo on iPhone, as opposed to the very sophisticated 3D camera. And then, as opposed to having the 5 image templates, we use sliders for the lip and the philtrum, where the cutoff points have been determined by experts. So it says compatible, that is score 4 and 5, or non-compatible 1, 2, and 3. So, and there can be different templates. However, these are AI-generated images, and one should understand that they are not real, and we will see how. So, what we know is that the faces are not as simple, and this kid has many other features, such as epicanthal folds, strabismus, down-slanting palpebral fissures, etc. We know that there are a whole bunch of features that are actually associated to the phenotype of FAS, and we are not accounting for them. We don't have a way to evaluate them. We've always thought they would contribute to the diagnosis of those patients that don't fulfill criteria for the fetal alcohol syndrome, but we can't really show that, and I think it's because we don't know how to evaluate them objectively, and we need to improve that. And those are the ones I think are important. So for example, for mid-face hypoplasia, which for Mike is very important, I think our main problem is how do we evaluate it subjectively in a patient, just visually, right? We have tried those arcs, those mandibular and maxillary arcs, and we are studying them. So, to tell you about my work in CIFASD, and I'm going a little slow, but I'll try to, we have trained a bunch of different examiners. We're trying to increase capacity, both for providers in the clinic and for researchers. And we do it in person and online. We have designed methods to evaluate the trainees, and those are observing and troubleshooting, reviewing the data for coherence, seeing the agreement between different methods, because if you get the same, you're reassured you're getting it right, comparing the agreement with experts, and analysis of 3D photos with exams. So, and also proctoring, watching exams. And we have also designed some materials that can help in the evaluation, like, for example, sample images also for these ancillary features. So, We have collected data at this time of up to 158 individuals, and this is what we see. And I don't want you to, focus that much on this, but basically what we see here, the further left, the better, right? So what we see that the agreement for the palpebral fissures between manual and the 3D placing the dots is a millimeter in the hands of an expert. So that is what we should aim for. That's what we want. And using both, we get better. It's a little less good for the trainees, right? And we do know that the agreement between examiners by method is best for the 3D. So we realize, 3D is good for that. So then the same thing for the philtrum. We see that the agreements are pretty good, but certainly it is better for the philtrum than for the upper lip. And I don't want you to go in detail with the data, but the way this affects, we are also even plotting, able to see exactly what happens. So we see that, the 3D is shorter than manual, the mesh is larger, the most, trainees measure in a certain direction compared, and how lighting and the technique is important. So how does that really impact the diagnosis? Well, there's great agreement, but we know, or we have seen, that very good performance of the Morpheus Q PFLs for the 3Ds, that for the philtrum and the upper lip, we probably need revisions of those cutoff points, that there's really a perfect agreement for these, for the 3D and the manual, which makes it that if we measure with both, we know we got it right. And then the disagreements are always in the same direction, so we know how to train. So I think that's also an interesting fact. And I think one of the things that doesn't work for the philtrum is that the philtrum doesn't flatten uniformly. I think the 4 is very often flat on the top and not at the bottom. And the 3D the AI-generated images are uniformly flattening the philtrum. So that's probably what we don't get right. So Mike is definitely teaching us how to better learn. We are correlating, studying the correlations between our exams and his photos so that we know what we're looking at great and not. I will finish in 1 minute. So what are we learning? There's much more to the physical features than the 3 facial features. How can we start using them? We can provide better training with several methods and tools. We were able to measure the results of the training so we can improve it, and we can improve our methods of examination. Just to comment that we are still doing work in San Diego, like you all are, but we're working with the juvenile justice, with the child and family welfare system, and just as a little bit of a promotion here, I would like you to go look at the fetal fentanyl syndrome, which I think is a real thing, and we're going to talk about it tomorrow. And I'm excited and frightened in many ways about it. Thank you. Sorry for going. Yeah. Any questions?
Yes.
Yeah.
Christie.
Michael and Miguel, the Michaels here. I work now most exclusively with kids with craniofacial differences in Vancouver, in British Columbia. I'd say about 1 in 5 moms, when I was really active, I can get a prenatal alcohol history in non-syndromic clefting. But I also wanted to say, in all of these, in wealthier populations, just like in our cleft populations, orthodontics changes our face. And I was thinking of CJ's comment and looking back that maybe we should start to take into account when we're seeing kids, if they've either been in a very supportive foster or adoptive home, or families have money, that we might be missing things in the facial features if we do that. And then I just did a deep dive on Pierre Robin, the dental surgeon, and he originally he was describing FASD in the 20s and 30s, guys, the glossoptosis and the micronathia, and when you start, and we're getting back to phrenology, I think it's super exciting what you're doing, but to be able to help guide us into what goes into the face and how that may be an indicator that we can support brain function through this, and not just with our ruler. So it's super exciting, but realize that the dentists may alter some of the measurements we're taking by the things that they do.
Yeah, great observation. Thanks. Okay.
Thank you so much. We're going to move on now. Jeff Wozniak from University of Minnesota.
All right, thank you. So I am going to talk a little bit about intervention study that we are working on, one that we've completed and one that we are working on. And this is going to be about transcranial direct current stimulation. So I'm going to talk to you a little bit about how we're using electrical stimulation to the brain in conjunction with cognitive training to try to improve things for kids with FASD. So I hope this talk will be stimulating but not shocking. Blake already showed some of our research group at the University of Minnesota. So I just thought I would include two quick slides to kind of orient us a little bit in thinking about, that there's an awful lot of brain development that happens during the pregnancy. And so before this line is gestation. And you can see all of these various characteristics of brain structure that are developing rapidly during those stages. So that's point number one. Point number two is that there's still a lot going on as we continue on through life in terms of white matter growth and gray matter growth. And these trajectories are all kind of unique and individual, but we're going to be talking in this age range out here today between about 8 and 17. So things are starting to kind of peak, but there's still a fair amount happening as far as brain growth. And then I just thought I would point out that anytime we're talking about prenatal alcohol exposure, we need to understand that the brain is impacted really at any point during the pregnancy. And without getting into all these details, in the first trimester, you have alcohol creating gross structural malformations in the brain. In the second trimester, you have a lot of impacts on the migration of neurons, and including the cortex. We're going to be talking about the cortex, which is the outermost layer of the brain. And in the third trimester, we have an awful lot happening as far as connectivity, how the networks form in the brain to handle information processing. So when we think about targeting interventions, we want to understand what it is we're targeting from a cognitive perspective. So if we're going to do something to the brain, we want to understand what we're doing to cognitive functioning. These are generally agreed upon areas where cognitive functioning is disrupted in folks who have FASDs. And today we're going to be really focusing on attention deficits and some information processing difficulties. Specifically, I'm going to be talking about working memory especially. So working memory has to do with, can you hold information in mind while you're doing something with it? And oftentimes when I talk to parents, what they will describe is that a person, a child, a teenager, will know something at one point and forget it at another point, or they may seem as though they're understanding it as they're learning, but they're not necessarily holding on to it, and they can be distracted easily from that information. This is a little hard to read here, but typically I see kids in the clinic, and our studies recruit folks from the clinic who have multiple types of issues. And so we sometimes want to know, do these problems occur in a typically developing population? So a large study, like Michael mentioned earlier, the ABCD study, thousands of kids not recruited for alcohol exposure. What do you see in terms of the most common things that are off of this vertical line here have to do with executive functioning, attention, concentration, and working memory? So we know these are real challenges even in the non-clinical populations where there's some comorbidity that we have to think about. So we've been doing neuroimaging studies. Blake Gimbel showed you some of those earlier, and we've tried to sort of pick apart, is there anything in this work that can guide us to thinking about interventions? And the intervention that I'm going to show you is targeting cortical functioning. So this is an example you've seen many times. This is not typical. We don't usually see these gross structural malformations when we scan the brains of folks with FASDs. What we do see is abnormalities in the wiring of the brain, and this was referred to earlier in one of the questions during Blake's talk. So we've spent a fair amount of time looking at the development of this white matter, or the fibers and wiring that forms the networks that process the information. When we have done these studies, we've shown differences in individuals who have FASDs in how they handle information processing at a brain level. So I won't go into the details here, but this is a typically developing child. This is a child with an FASD, and we can measure at the brain level where those abnormalities are occurring. This slide, I'll just point out that these small percentage differences in efficiency of how the brain is handling information actually make a big difference for the person. So typically we talk about, with these types of studies, somewhere in the 1 to 3, maybe even up to 5% decrement in the efficiency of the network handling the information. So as we're designing interventions, we want to think about things that might be able to reverse that, or at least attenuate that. I wanted to mention that we have looked specifically at the cortex. This outermost ugly, wrinkly layer of cortex is actually pretty important for the brain. It does a lot of the higher cortical functions that we think of as intelligence. And in fact, the brain is smoother in FASD because of the impacts of alcohol on the development of the cortex, and that's associated with IQ. So there are real-world consequences to this smoothing of the brain. These are foundational injuries, which I've talked about yesterday a little bit and many other times. We're not going to go back and correct all of these deficits, especially when we're talking about the age range that I'm going to be describing here, which is school-age kids, let's say 8 to 17. But I think we're still in the middle of a paradigm shift where we're understanding that we really should be not just accommodating to people's deficits and changing the environment, but we really should be thinking about, is there brain development that we can go back and try to take advantage of while it's still happening? And in this age range here, again, this 8 to 17 age range, there's still, some things happening in terms of brain development. Some things are tapering off, and as it was mentioned by Sarah Matson, that by your 20s, some of your cognitive functions are no longer peaking, they are kind of flattening out. We have reached some peaks in adolescence that we can't get past. If you're thinking about interventions, you really ought to be thinking about this set of circles here, and they should be designed for specific individuals, maybe an age range, at what point in development, and we should really be thinking about targets that we want to measure. No intervention is going to solve more than one problem for an individual with an FASD. So I'll just spend the remainder of my time talking to you about brain stimulation. And what we're using here is not electroshock therapy. It's very, very mild electrical stimulation to the to the scalp, and it goes through and basically changes the level of a threshold of the firing of the neurons in the cortex. And so that's what's depicted here. It's just a slight change by adding this very small amount of voltage. This figure over here is just showing you the number of studies increased that have been published using this technique. So there's a lot of interest in transcranial direct current stimulation right now. We think that this enhances plasticity, and I'll show you some data to suggest that might be happening. By itself, it doesn't do anything. So if I put my cap on your head right now and we stimulated, we wouldn't necessarily achieve a cognitive effect. There are some studies that show some benefits for mood and anxiety can be enhanced, can be achieved with just straight stimulation, but for cognition, we have to do something else. We have to be doing some mental activity at the same time that we're stimulating the brain. And if you remember this phrase, this will help you understand. Cells that fire together, wire together. What we're trying to do is get the brain to fire certain cells together so that they strengthen those connections. And what we're hoping to achieve is improvements in these high-level skills: attention, working memory, and speed. We know that this is not a one-shot thing. This is going to require multiple sessions. We think that the more sessions that you do of this kind of therapy, the better. And we know that it's not going to generalize to everything. So doing a therapy like this is not going to solve all of your cognitive processing problems, but it may address some of them. This is one of our early studies, which we've already published using this cap here. It's called StarStim. And we were stimulating here in a region called F3, which is the dorsolateral prefrontal cortex. This has a lot to do with working memory. There are a lot of studies that show that. And we randomized kids to 5 sessions of active stimulation, 2 milliamps, very, very small voltage, or sham, which means that they're not getting any stimulation. You can see this produces a large field. It's not a localized, very precise effect. It's really affecting a good chunk of brain when we're doing this. And we have some people ask, how do you blind this? Does everybody know if they're getting stimulation or not? We have some techniques where we ramp up the stimulation, then ramp it back down. And so we can kind of blind people to it. And there's some specific things about the paradigm that you don't just stimulate someone straight for 20 minutes, because the brain would adapt to that kind of level of stimulation and say, okay, I've had enough of this and I'm not going to respond in the same way. So we use some tricks to stimulate, then have a break during the middle, and then stimulate again. Typically we're using like a 13-minute stimulation, 20-minute off, and then 13 minutes. The whole time that the person is getting this stimulation, they're engaged in cognitive training. And I'll show you a picture of what that looks like. So we did a pilot study, 44 kids, 5 sessions, and this is not the end result. This is kind of baby steps working toward seeing if we can even demonstrate an effect. And we test cognitive testing before and after to try to see, have we changed anything as far as their memory or their speed or their working memory. And the results of that, well, before I get to results, this is what the cognitive training looks like. A child might be sitting in front of a screen, counting fish. You know, maybe those fish disappear and then they have to remember where they were before they disappeared. That would be an example of a spatial working memory task. And they're varied. These increase in difficulty. We repeat them, but there's sort of an intensity to it, and that is something that we know about cognitive training, is that you need to increase the intensity in order for the brain to kind of consider it important, and you need to make it engaging. So we try to engage kids motivationally to be wanting to do these tasks. We move the zone of difficulty. So this is an old Vygotsky idea that you want to always be in the zone of challenging an individual when you're trying to teach them something, and this applies to behavior as well. But we think about this when we design these cognitive training paradigms. We don't want the tasks to be too easy. We don't want them to be too difficult. We want them to be right in the zone where the child is at the edge of their capacity. And what we showed in this first study is that this was pretty doable. So we had about 86% of people complete this study. We didn't have any differences in side effects. We ran over 200 sessions of this, and we're doing this left dorsolateral prefrontal cortical stimulation. We had a continuous performance test, which is a standardized measure of attention, concentration, as one of the outcomes. And what I'm showing you here is the difference by 5 sessions. This is session 1, 2, 3, 4, 5 down here at the bottom. And this is the group that got the stimulation. And you might say it looks like they're getting worse, but that's actually the variability of their performance is actually decreasing. They're getting more and more tight in their performance over the sessions. So that's an improvement that's due to the stimulation alone. And that's an example showing you that it doesn't affect everything. So this is spatial working memory. Both groups improved, no difference with the electrical stimulation. So that's kind of what we expect for these kind of trials, is that we're going to see effects in some areas, but not across the board. We did see an association for the active group between their improvement on the CPT, which was that attention test, and the parents' ratings of their actual attention day to day.
I'll skip that. I'll just mention that what we're doing in CIFASD now is extending these results. Those were 5 sessions of this treatment. We're now testing 10 sessions. And with the onset of the pandemic, we developed a unit that can be administered at home. So this is actually my kid right here testing this out on a laptop. And this is the stimulating device. There's the headband that delivers the stimulation. And we do these on Zoom. So we actually do the first session and the last session in our lab, and the rest of the sessions are done at home. And so this is a scalable intervention. This is what it looks like when someone's performance is improving on some tasks and not on others. And I think that this has a lot of potential. Ultimately, what we're doing now is baby steps, trying to show that we can detect an effect. But ultimately, you could imagine even a closed-loop system where someone might be wearing one of these caps on their head, and that would also be measuring the brain activity at the same time as is delivering stimulation. So I think we're at the early stages, but encouraging, and CIFASD is helping us to kind of develop the parameters of this kind of a novel intervention. Thank you very much. Questions?
Hi, I'm Sarah Hammersmith. I live in Syracuse, New York, but I'm from Minnesota, and I'm wondering if I can bring my 15-year-old son to Minnesota twice to be in your study. Is that a thing?
For this particular study, we have people who drive maybe a short distance. It's actually a little bit more than two visits, but we can talk afterward.
Fantastic. I do have one other question, which is, can you just clarify a bit more about how this is different from what neurofeedback options have been for some time?
Yes, good question. So neurofeedback is generally feeding back information to the person about what's happening with their brainwaves, essentially. And so those, I think, can be very good techniques for training kids to become more in tune with their own rhythms and their own concentration, for example. This is actually, that doesn't involve any stimulation, so you're not adding any electrical energy into the brain. This actually is adding a very, very low dose of electricity to the brain.
Hi, I'm from Minnesota. My wife and I are...
It's a party.
And I'd like to connect with you afterwards as well. We have 2 boys, almost 8 and 11 years old.
Great.
So, yeah.
Fantastic. Yeah, we would love to have more participants.
I have a question, which is you're targeting a specific brain area. Have you considered other brain areas that might be even better potentially?
Yeah, so, these studies, we need to accumulate a certain number of people in order to demonstrate an effect, so we had to pick a brain region. A lot of this work that's been published has been in the dorsolateral prefrontal cortex, partly because it's a reasonable area to stimulate. We can't stimulate the hippocampus, for example. It's too deep. There have been some interesting studies, or at least proposed studies, looking at occipital stimulation and maybe even cerebellar stimulation, which would be potentially interesting. So I think it's sort of an open field at this point, yeah.
Thank you. Our last presenters are Christie Petrenko and Cristiano Taparello from University of Rochester. This is forward, backward, and laser.
Okay.
Awesome.
Perfect. Thank you.
Good start.
So thank you, Michael, and thank you, everybody, for sticking with us until the very end of this session. So Christie and I today are going to talk about the work that we've been doing for the past 8 years in bringing technology into intervention for FASD. I want to acknowledge that all of this work has been sponsored by NIH, with 2 grants through CIFASD and 1 training grant that one of our graduate students obtained a few years ago. So we all know that people with FASD face significant barriers to actually getting care. Maggie and CJ did a fantastic job yesterday talking about stigma, and how stigma is affecting the way in which they actually can get access to this, to care. But then if we look about society and communities, there is very limited knowledge about it, that then reflect into very few providers that actually can provide FASD-informed care. And in the end, there are many areas around the US or around the world where there are no even services that can be offered to people with FASD. So I believe that is, looking about what Mike was saying about the pivotal moment, for me, the pivotal moment was Steve Jobs getting into the stage in 2007 and bringing in an iPhone, that I think that changed our life forever. So now everybody's on a smartphone in our pocket. We saw the evolution of computers and personal computers, but we are carrying so much power in our pocket that we can harvest and potentially breaking down some of these barriers. So what I've been doing for the past 8 years or so, we've been working on different type of projects where I'm a computer engineer, and we bringing together a clinical psychologist, and we actually can take over the world. So general companies, they work through, the software companies, they work through this general framework where they start with having an idea, they break down what the functionality they want to bring into the product that they are developing, then sketch down what they think the app or the website is going to look like, and then they start to building up like what we call interactive prototypes. So think of it, you're sketching down what you think the app should look like, and you start putting arrows and saying from this particular screen, I'm going to go to this one and then to this one, so that you're actually creating a flow how the app is going to look like. There are some sophisticated tools for doing this, but it is, and then you do some refinement, and in the end you get it to the end of a software engineer that, depending on the particular framework that they were using, they're going to bring it into a real product. So we are not just computer engineers, we're not just a software company, we are researchers. So, and we saw that over the years involving key stakeholders into the entire project is essential. So as once you have the functionality, do focus groups and interact with real people so that you actually know that you're going to be making a product that is useful and is relevant to people that then is going to be your customers or your users at the end. Once you get into something that you can actually show, just show it in focus groups and see what the feedback you're getting, and then in the end you can use your stakeholders for doing beta testing and making sure that everything actually works as you're expecting. We're also researchers, so you go down and you actually do trials, randomized controlled trial, and you're actually trying to test that the science that you're building actually works. And you're not just delivering something that seems to be useful for people, but it's actually making changes by just using the technology itself. I'm going to pass it over to Christie.
Yeah, we're tag teaming this today. So what Cristiano and I would love to show in our short time today is just kind of give you an overview of some of the different types of digital and mobile technologies that we've been developing using this framework to reach a wide range of different types of people and systems to show sort of what can be possible. We're not going to go into a lot of nitty-gritty detail, but sort of give you an overview about what we're trying to achieve with this. So the first study, what really started this work together, is a program called FMF, or Families Moving Forward Connect, which is a self-directed app that we created for caregivers, because we know that there are some great evidence-based interventions that have been developed and tested for FASD, but very few of those are available to people in the community. So we wanted to create a direct to consumer product that can really go to a big scale to reach families. So I'm going to just highlight a little bit of how we developed this project and then showcase a few others that we have. So this FMF Connect app was developed through a partnership with Heather Carmichael Olson and her team. So Heather developed a program probably about 20 years ago called Families Moving Forward, and it's a specialist-led program that really works with families over a sustained amount of time to help them better understand and support their children using strategies that you see here. And if you want to learn more, there's a table out in the Florida Center has a table that can share you more about this. But so we really thought through the methods. We really spent a lot of time thinking about how do we translate something that's done by a therapist to be done by a family on their own. And so what we came up with was what you can see here is the Families Moving Forward Connect app, and it's got 5 main components that you can see here, like learning modules, there's an extra library of materials, notebook, dashboard, and a way for families to connect with each other. And we went through a very careful, systematic approach to develop this app over the years. This was funded through CIFASD 4. And you can see we moved from that initial focus groups like Cristiano highlighted all the way up to doing what we called our efficacy trial to see, does this actually work when families use it on their own phones? And so in that study in 2022, we analyzed the findings and found that, yes, the app does result in benefits for the family, which included areas such as increased FASD knowledge, parenting satisfaction, perceived needs being met, and this idea of reframing, sort of thinking about your children's behavior. Now, these are smaller in magnitude that you get with the in-person program, but with an app, you can reach a large scale number of people. And so we are working on getting this into app stores soon over the next few months, hopefully, so families can access. I'm going to go ahead and hand this over to Cristiano, and then I'll be back to tell you how we went to the next step with this project.
Thank you. So Christie was talking about FMF Connect, which was mostly targeting caregiver raising children 3 to 12. We also work into building apps for adults. So we know that FSD is a lifelong condition. So you see one of the app that we call My Health Coach that we built in the past few years, and you can recognize some faces here. So actually this is part of our research team. They are members of the Adult Leadership Collaborative or FSD Changemakers. So once again, going back into including key stakeholders into the project, into your project, and into the app development since the very beginning. So the development of the app started around 2021, where we established our partnership with ALC. We did some initial focus groups in order to try to understand with adults with FSD what they think would be helpful for them. We then moved in collecting an online survey that was built in collaboration with the ALC in order to get more feedback and actually trying to figure out if what we were envisioning was actually thought to be useful for adults with FSD. And then we did a small scale study that was open worldwide with 43 adults that were involved in around 15 countries, I think, around the world, and to finish up in 2023. Where we are now, we actually opened this past week recruitment for our final study. So we are looking for adults all around the world that wants to test out our app and give us feedbacks in order to figure out what's the next steps are going to be there. So I'm going to pause it if you want to. You need to take a pictures, but you can find additional information outside. Can go. Sorry, guys. Good. So we talked about caregivers. We talked about how we can reach adults. Then our team actually started to look into what we can do in order to try to change systems and like schools or mental health settings, where what we can actually bring to those settings. So this is where graduate students from Christie's lab, Carson, Couch Turnbull, she worked into trying to bring an intervention for teachers, actually teaching teachers how to handle kids with FSD. What I'm particularly proud about Carson, even if she was one of Christie graduate students, is that she built up the entire website on her own. So she got very limited training from me, and then she built up the entire system, the entire website on her own. So that's actually getting a psychologist doing that was what I consider a big success. And she actually used a framework. I'm not going to go into all the details of the framework, but the idea that she started with finding an idea of assessing what was the requirement for actually bringing the entire program into a school system. And then she made the decision about what type of intervention to actually implement. And she involved topical experts. Once again, she didn't know anything about websites development up until she actually started interacting with me. And she did at the end some testing with some teachers in order to try to understand if that was useful. Back to Christie.
Yes. So, as Cristiano was talking about, we not only wanted to bring products to individuals, but thinking about, okay, how do we get into systems? So we spoke about this yesterday at our 90-minute symposia on the development of the FMF Connect Pro system, and I'm happy to give a little words here, but talk more about folks who are interested to learn. But this is our approach of how do we get into the mental health system. We have the FMF foundations, or the standard FMF program, which trains specialists, but those are specialists that generally know about FASD and have identified clients in their care. And we know we have our app for families, but there's a big group of mental health providers in the middle there that have fairly, I would say, entry-level or introductory information about FASD, which might be little to none. And so we wanted to try to figure out, how do we get that base in the middle to have some competence in FASD-informed care? And so we developed this program that teaches mental health providers 3 key skills. So we want them to do routine screening of prenatal alcohol exposure. And so that's a foundational skill that all mental health clinicians should be able to do, and to help identify kids. And then we train them on how to use the DSM-5 criteria, which is developed for mental health system, or NDPAE. And then we provide easy-to-access resources that don't require them to do an extensive amount of training, but gets them started down that path. So we teach mental health providers how to support caregivers using the app. So it combines their skills in mental health therapy with this resource that gives them that foundational knowledge in one place. And so to do this, we know mental health providers are really busy and, have a lot on their plate. And so we developed 2 different training methods that we are testing out to see how they work and who they might work best for whom. And so the first uses an approach called ECHO, which this is a synchronous learning where we organize groups of mental health clinicians together to come and learn from each other. And so we give them a brief didactic training on a key skill like how to screen, or what's reframing, or what are accommodations. And then they bring cases from their caseload. They de-identify them and they present and get feedback from others in the group. And so it's a way for them to really apply that learning over a sustained amount of time. It also creates an accountability if you're supposed to show up at Monday at noon and really keep that learning going. We have another approach too that's just self-paced. So our self-paced group gets the exact same didactic training content on brief videos. I think our longest video is maybe 15 minutes. So they log into the website when works for them, they watch the video, do a couple of activities, and really sort of learn that on the time that works best for them. And both of these groups get access to a dashboard website that we have, and which can link with the caregiver app so they can see what their clients are doing. And so we are doing currently a randomized controlled trial to test these approaches and see, one, can we increase provider knowledge, competence, and use of FASD-informed care in their practice? And so we're enrolling, we're targeting certain states where we go in and really try to reach a wide range of providers. But we also have recently opened it up nationally. So for any mental health providers, or if either yourself or colleagues or other agencies that you think might be a good fit for this program to really build FASD-informed care in your communities, these are the QR codes. We'd be really happy to talk with you further about this. And we really see the FMF Connect Pro program being a good fit for mental health therapists that are pretty new to this, which is most providers. And this program is really designed to be flexible and to fit into a lot of different kinds of settings like integrated behavioral health, inpatient, outpatient, different kinds of settings that have some flexibility. I also wanted to highlight, a couple of these programs that we've been talking about are part of the Families Moving Forward Continuum of Care. If you'd like to get a copy of this continuum and learn a little bit more about some of these different tools, the Florida Center has a nice handout. We also have at the CIFASD table some more recruitment information. Also, feel welcome to contact us. We'd love to brainstorm ideas of how we might be able to get resources into your communities. Our next big adventure is, we've worked with caregivers of young children and we've worked with adults, but there's a lot of need for our teens and caregivers in that age. So in just a few months, we are going to start this process that we've gone through to try to figure out what teens and caregivers, what they might be find helpful in an app-based program. So more to come on that. We currently are calling it Determined, but we will see what that evolves into. This is our fantastic team on CIFASD. You can see we have our research team locally, Cristiano and I as principal investigators. We have a number of fantastic co-investigators, our Echo Hub team, grad students, and the ALC who we partner with. And we, I think, have time for questions. And again, if you want the QR codes for both our My Health Coach study and our FMF Connect Pro study, those are there.
Hi there. Yeah, I'm wondering, I saw obviously mental health providers and teachers resources. Are there resources for related providers such as OT, SLP?
We have not pursued that direction yet. I do have a student that's looking within the child welfare system and thinking about CASA volunteers as a way that might be used to leverage that resource in child welfare system and family courts to increase identification and supports for families. But that's a really interesting new direction to explore about some of the allied health and OTPT, because that would be a great resource too. Maybe CFAS 6.
Okay, I've just been advised not to break this. Christie and Cristiano, yay! I don't have any favorites. I was just wondering, could that be, because another question was about like family courts and stuff. Do you think law enforcement would be interested? Because, I mean, there was a statistic like 40% of people with an FASD end up in jail, and I'm hoping to see that reduced. But is there any way that like service providers or community engaged cops would like this information?
I mean, I think really I think that deserves a clap. Thank you, CJ. I mean, I think there are so many different sectors and systems that need to be FASD informed, and I think the key thing is, when we think about this, is what would be the needs and functions that, for example, law enforcement might need, and what would fit into their life, which that has been a big question of like, apps are cool and fun, but like, not everybody needs an app to get that information. Teachers were like, we don't want apps, we want a website. And so that informed that. But I'm sure there could be some really interesting ways that technology could help support different professions, like OTPTs, and other things like in law professions. So.
Hello? Okay, perfect. No, this is great, and just to be, I think, very transparent, so I have a poster out there for artificial intelligence and its use within the justice sector and how you can get resources right to SMS. And I think listening to you, it's so interesting to see in the next decade how we develop things, and it might not be, in that same structure. With now that you have different models coming in, you can kind of speed up development time and try and see, what's out there. But for this determined application, are you looking to, what is sort of your path and steps there? Because I would love to talk to you after this and see what we could do.
Well, at least from a content and basic functionalities, we'll probably follow a very similar sort of method. So our plan is to, among our team, we'll gather some teens and caregivers to get their input on what they see is needed. We'll brainstorm ideas together. We'll do some focus groups after we develop the initial concept to refine that. And then we'll start putting it in interactive prototypes and trying it out, and then getting it into an app and sort of move through that way systematically. But we have some ideas already of like what kind of content might be there, but that's my ideas. That's not really what the users necessarily say. So we're going to go to them first and be like, what would actually be helpful? And, you know, what are the issues with teens and apps and caregivers, and what can they do to help, and what are the problems? And so we'll really dig into that.
Yeah, no, awesome questions. This is great.